Dyspepsia. It's one of the most common things you'll see in pretty much any clinic, but getting the management right can be surprisingly tricky. So, today we're going to break down the joint guideline from the American and Canadian GI societies to give you a super clear, evidence-based roadmap. All right, let's get right into it.
And why is this such a big deal? Well, how about this number? Managing dyspepsia costs the U.S. healthcare system over 18 times billion-dollars a year. Yeah, you heard that right. And that's not even counting things like lost productivity from people taking time off work. So getting this right really matters, not just for our patients, but for the whole system.
Okay, first things first, let's make sure we're all on the same page. When this guideline talks about dyspepsia, it means one specific thing: predominant epigastric pain. You know that pain right in the upper, central part of the belly that's been going on for at least a month. Sure, other symptoms can be there, like feeling full or nauseous, but that epigastric pain is really the main event.
So, here's our game plan for this explainer. We'll kick things off by looking at just how big this problem is. Then, we'll hit the first, and maybe most important decision point: your patient's age. After that, we'll walk step by step through the algorithm for folks under 60, talk about what to do for functional dyspepsia, and finally, cover those cases where the standard approach just isn't cutting it.
So, just how widespread is dyspepsia? It is absolutely massive. When you look at systematic reviews, they show that something like 20% of the entire world's population deals with this. Think about that for a second. 1 in 5 people. It obviously has a huge impact on their quality of life, and, like we saw, it comes with a staggering price tag. All right, we're now at the very beginning of our clinical path. A patient walks in with new onset dyspepsia. The first question you have to ask yourself, and this is the most critical one, is all about their age. This single piece of information is going to dictate your entire initial workup. And that really boils down to this one question: who needs an immediate upper endoscopy to look for something serious, like a malignancy? And who can we manage in a less invasive way? Well, thankfully, the guideline gives us a very clear answer.
And boom, here it is. The big dividing line. The age cutoff is 60 years old. For any patient who's 60 or older and comes in with dyspepsia, the guideline says you should suggest an upper endoscopy to rule out anything serious. But for everyone under 60, you're going to start with a totally non-invasive approach.
Now, you might be wondering, why the change? Previous guidelines used to say 55. Well, the authors are really clear about it. They basically say that the rates of gastric cancer have continued to drop in North America, which means scoping younger and younger people just isn't cost-effective anymore. It's a practice change that's driven by real-world data.
Okay, now this next part is a huge practice-changing point, so listen up. We were all taught that alarm features, things like weight loss, anemia, or really bad vomiting, should automatically trigger an endoscopy no matter the age. But the evidence reviewed for this guideline found that in patients under 60, those features just aren't very good at predicting cancer. The risk is simply too low to justify scoping every single one of those patients.
All right, so if we're not sending our younger patients for an immediate scope, what do we do? Let's dive into the under 60 algorithm. This is the evidence-based pathway for the vast majority of patients with dyspepsia that you're going to see. It's a pretty straightforward 3-step process. And get this, it's a strong recommendation backed by high-quality evidence. So, step 1, you do a non-invasive test for H. pylori. Step 2, if that test is positive, you treat it. Step 3, if the test comes back negative or if their symptoms are still there after treatment, that's when you start a trial of a proton pump inhibitor, or a PPI.
And here's the data that makes the case so compelling. When you compare this test and treat strategy to just sending everyone for a prompt endoscopy, there was basically no difference in how many patients felt better after a year. But just look at the cost. The test and treat approach saved an average of over $400 per patient. We're talking the same outcome for a lot less money.
But what happens when you've done the workup? Maybe the patient is over 60 and their scope came back totally normal, or they're under 60 and they've already failed that first algorithm. Well, now we're in a different territory. We're talking about a new diagnosis: functional dyspepsia. And just to be super clear, functional dyspepsia is the official name for when a patient has all those classic symptoms, but you've done an endoscopy and there's no organic cause, no ulcer, no inflammation, nothing that explains why they feel the way they do. It's a classic diagnosis of exclusion.
For these patients, the guideline gives us another really clear step-by-step ladder to climb. First, if they haven't been tested yet, you check for H. pylori and treat it.
That's a strong recommendation. If that doesn't work or they're negative, a trial of PPIs is next. Still no luck? Then you can conditionally try a tricyclic antidepressant, or a TCA. And finally, you might consider a prokinetic, but just know the evidence for that is pretty low quality.
This chart really visualizes just how effective these treatments are. The number needed to treat, or NNT, just means how many people you have to treat for one person to get better, so a lower number is way better. You can see treating H. pylori and using PPIs definitely work, with NNTs around 12 and 10, but check out the TCAs. Their NNT is just 6. That's actually amazing, and it makes them a surprisingly powerful option for those tough cases.
Of course, medicine isn't always black and white, right? Not every patient is going to fit neatly into these boxes. So what do you do when you've gone through the whole algorithm and your patient is still miserable? Well, the guideline gives us a few pointers here too.
So here are the key nuances. First, routine motility studies, nope, not recommended. But if a patient's main complaint is really severe nausea and vomiting, making you think about something like gastroparesis, then a gastric emptying scan might be a good idea. Interestingly, psychological therapies can be offered, and they have an incredible NNT of 3, but you have to know the evidence quality is very low. And finally, the guideline says not to recommend complementary or alternative medicines because there's just not enough good data.
Phew! Okay, that was a ton of information. So let's just boil it all down to the absolute must-know, practice-changing takeaways from this whole guideline. First, if you remember only one number from this whole thing, make it this one, 60. That is your new age threshold. Patients under 60 with dyspepsia do not need a routine upfront endoscopy. It's as simple as that.
The second big takeaway is your new mantra for younger patients: test and treat. You always perform a non-invasive H. pylori test and treat them if it's positive before you even think about an endoscopy referral or grabbing that PPI prescription pad.
And third, for your patients who have a confirmed diagnosis of functional dyspepsia, commit this treatment ladder to memory. Start with H. pylori, move to a PPI, then consider a TCA, and last, maybe think about a prokinetic. Just follow the steps.
So I'll leave you with this one last question. Think about the last few patients you saw with dyspepsia. Does your current practice line up with this high-quality evidence? This guideline gives us all a really clear, effective, and cost-conscious path. The only thing left is to put it into practice.